All right, let's dive into some clinical management pearls for chronic kidney disease. We're going to focus on the really high yield stuff you need for your daily practice and for those specialty exams. We'll cover how CKD can be super subtle in its presentation, and then get into the nitty gritty of managing the hypertension that almost always comes with it. So here's our game plan. We'll start with why CKD is so often missed early on. Then we'll look at what happens when things get more advanced. After that, we're all about management, tackling hypertension, why AC inhibitors are our go-to, and the special role of furosemide. We'll wrap up with some crucial patient safety advice. Okay, first up, let's talk about the biggest challenge with CKD. Actually, finding it. This disease is famously quiet in its early stages. That means we have to rely on proactive screening and just stumbling upon it. So picture this. A patient with early CKD probably isn't going to walk into your clinic with any specific complaints. The diagnosis is almost always an accidental finding. You've ordered a urea and electrolytes panel for some other reason, and bam, the results come back abnormal. That's the classic presentation, or, lack of presentation, that we have to be super vigilant about. But as that kidney function starts to decline, that asymptomatic picture really begins to change. Let's get into the clinical signs that start popping up in late-stage disease right when the kidneys just can't keep up anymore. So what's going on here? Well, these late-stage features are really driven by two things. First, the kidneys can't handle sodium and water properly, which leads to volume overload. That's where you see the edema and hypertension. And second, you get this buildup of uremic toxins in the blood, causing all sorts of systemic problems, that really intense itching or pruritus, plus loss of appetite, nausea, and just feeling wiped out all the time. And that brings us to management. Honestly, getting that blood pressure under control is probably one of the most important things we can do to slow down CKD progression. It's an absolute cornerstone of care for these patients. And this really highlights a key challenge. Hypertension in CKD isn't simple. It's caused by both that volume overload we talked about and the renin-angiotensin-aldosterone system going into overdrive. Because of that, just one drug is hardly ever enough. You're almost always looking at a multi-drug regimen as the standard of care. So where do we even begin? Well, the guidelines are crystal clear about our first-line agent. Understanding how it works and, just as importantly, how to monitor it is absolutely crucial for practicing safely and effectively. Yep, ACE inhibitors are our go-to. And here's why they're so great. They don't just lower systemic blood pressure. They have this special effect where they dilate the efferent arteriole. That's the little vessel leaving the glomerulus. This lowers the pressure inside the kidney's filtering unit, which reduces proteinuria, a direct sign of kidney damage. That's why they're so vital in something like diabetic nephropathy. And of course, if your patient gets that classic ACE inhibitor cough, ARBs are your go-to alternative. Now, this next point is so important. When you start someone on an ACE inhibitor, you have to expect a small drop in their GFR and a little bump in their creatinine. This isn't a bad thing. It's actually a sign the drug is doing its job. It's the direct result of lowering that damaging pressure inside the glomerulus. So how much of a change is acceptable? This is a key number for practice and for your exams. According to the NICE guidelines, a drop in eGFR of up to 25% from where you started is considered an expected and totally acceptable response. And for serum creatinine, it's a similar story. A rise of up to 30% from baseline is also considered okay. You really need to commit these numbers to memory: a 25% fall in eGFR and a 30% rise in creatinine. Those are your upper limits for an expected therapeutic effect. This, of course, begs the question, what are you thinking about when that creatinine jump is more than 30% after starting an ACE inhibitor? What's on your differential diagnosis then? And here is your high-yield answer for both exams and the clinic. If that rise blasts past the 30% mark, you need to start thinking about underlying renovascular disease, like bilateral renal artery stenosis. In that situation, the kidney's blood flow is desperately reliant on angiotensin II to constrict that efferent arteriole. When you block that with an ACE inhibitor, you can cause a sudden, sharp drop in the GFR. Okay, so since we know most patients are going to need more than one drug, what's next in our toolkit? Let's talk about a real workhorse in CKD management, the loop diuretic, furosemide. Furosemide becomes incredibly useful as the GFR drops and patients get more and more fluid overloaded. You see, unlike thiazide diuretics, which kind of lose their punch at lower GFRs, loop diuretics like furosemide keep working. They are fantastic for managing that fluid retention that's driving the hypertension in advanced CKD. Now, here's a classic exam question. When do you start a loop diuretic? Well, the guidelines differ slightly. In the UK, NICE suggests starting when the GFR is below 45. In the US, the NKF KDOI guidelines use a lower threshold of below 30. It's actually pretty useful to know both. And just 2 final pearls on furosemide. First, it helps get rid of potassium, which is a huge plus because CKD patients tend to run high on potassium, especially if they're also on an ACE inhibitor. Second, don't be shy with the dosing. You often need higher doses in CKD to get the job done and overcome what we call diuretic resistance. And finally, let's talk about a critical patient safety issue, the sick day rules. It is so important that we educate our patients about this. If they're on drugs that can affect the kidneys or blood pressure, we're talking ACE inhibitors, ARBs, diuretics, even NSAIDs, they need to know what to do. If they get sick with something that could dehydrate them, like a bad stomach flu, they should temporarily stop these medications to prevent an acute on chronic kidney injury. And this really leads us to a final, very practical thought. Look, understanding all the pharmacology is one thing, but what really prevents harm in the real world is effective patient education. So the big question for all of us in our practice is this: how do we best communicate these sick day rules in a way that truly empowers our patients to manage their own safety? Getting that right is an absolute cornerstone of high-quality chronic disease care.